This is increasingly the shape of things as we try to do research that tackles complicated issues, that we need all hands on deck, but also all eyes bringing different looks, all brains bringing different skill sets. We're really fresh out of issues that can be solved by one person coming up with one good idea, and there you go, I solved it. In that way, doing research with impact, with all hands on deck, becomes more and more important. Another really important thing is to have institutions that we can trust. Just about that, we have Dr. Meaghan Thumath, who's an assistant professor at UBC School of Nursing and a clinical scientist. And her talk is about trust-ready systems in complicated health emergencies. I don't know what a complicated health emergency could be, and I'm sure nobody has any guess at all. Meaghan.
Okay, first step, learn how to move the slides. Done. So I'm very happy to be with you this afternoon to talk a little bit about my experience working in health emergencies. So starting off with a bit of storytelling, this is my colleague Prudence and DJ, and I had the huge honor to work and learn from them in the Democratic Republic of Congo, or DRC, working on the Ebola response. And one of the most powerful things during Ebola is you've probably seen it on the news, it's EBD virus, very serious hemorrhagic fever, and it really gets people terrified. And so we'll often have an influx of responders come from all over the world. People will mobilize a lot of resources because it's really important to contain a hemorrhagic fever because it's so deadly. But with that influx, if we're not careful to pay attention to trust and relationship, we can actually make the system worse. And so in Goma, we set up these beautiful treatment facilities, or we thought they were beautiful, and there was ETC centers, we call them, and there was lots of bells and whistles, but everyone who went through those doors, which was very few people, never came out the other end. And you can imagine as a community member seeing all of these folks wearing literal spacesuits in your community, because we were wearing all of our personal protective equipment. And you're like, there's all these space agents coming in here, and where are they from? And I send my loved one in there, and they never come out. And everyone was coming out in a body bag because they were presenting so late. It was very hard for us to help them. And so it wasn't until we had wonderful, brave women like Prudence came forward a little bit earlier. Ebola is actually quite treatable if you came to us early. She bravely came, was able to get treated and survived. But the most remarkable thing we learned was that Prudence was actually the most important person to tell that story. And both her proximity to the community meant that she was a trusted community member. She already had that trust, but she was also, a fabulous brand ambassador because she had survived. And so having people, it's a strategy of using influencers. That is probably why I'm wearing these red Adidas shoes. I saw the TikTok ad and bought them. That's what works, and it always strikes me, those of us who work in kind of social justice and health equity work, it's taken us, I think, a long time to realize, we need to use those same resources and be able to think through how influencers can be used to transform and reduce unfair and unjust differences in health outcomes as well. So that's a little bit about Prudence. I'll be talking a bit about my journey in health equity, and you see I have it sort of as a red thread throughout my career, which has really been in these kind of core three areas. So I've worked in HIV and really got my start in the HIV/AIDS pandemic, which many people sort of forget was one of, in my lifetime at least, one of our most important and many lives lost pandemics. And then again have worked for many years in the toxic drug emergency, so really enjoyed, I think it was Alexa's presentation earlier on that, really resonated. And then I've also been more recently applying some of those lessons from the HIV and overdose work to a more broader basket of communicable diseases. So I worked on the COVID response, as I mentioned, EVD, Mpox, and many others. Before I go too far into my kind of pitch for why I think trust is such an important skill for us to be working on, a little bit about my own positionality. So she, her, white settler woman with Irish and Scottish and a bit of English. My mother always reminds me roots, but I identify a lot with the rebellious Irish side. And I was really lucky to work at a needle and syringe program as someone with lived experience early as a teenager. So worked in the kind of HIV prevention space and had, that's me on the right with my son. I'm 19 there, so I was a teen mom, and met, I think, some of the public health nurses who inspired my career. Hadn't realized I was tagged for a health equity intervention. I think they asked if I wanted free milk, and I was like, sure, I'm broke. I'll take the free milk. I was probably being surveilled because I was a young, at-risk, I was probably tagged as an at-risk mom. No one took my baby away, probably because of white privilege. And I was able to parent my son, and so that was, something I remain really grateful for. And I sometimes like to say he saved my life, and they're incredible. But yeah, I felt such a calling to this work in the harm reduction space because it really felt like those were my friends who were dying. And one of my first nursing jobs was on the HIV ward at St. Paul's, but I also had the great privilege to work as a street nurse with the BC Centre for Disease Control. And so that bevel up picture is from a film that Nettie Wild worked with us on. And then wanted to combine that passion of working with sort of HIV and harm reduction with my maternal child health passion. So I ended up at a place called SheWay. Does anybody know SheWay? Yeah, it's an amazing pregnancy and addictions project. Again, Coast Salish for women. Learned so much from that program. Still remains probably where like my clinical heart is. And that's an incredible, I think if you ever need a crash course on how to do good health equity programming, that's a place I would recommend you visit if you don't know it. And my work at SheWay I did a master's in public health, and then what made me decide finally to do my doctoral work was just feeling so frustrated that the system wasn't listening to us around the impact of child custody loss, and particularly on women's health. So my patients kept dying, and they were ready to parent. They'd followed all of the rules that the social worker had asked them. We had really good relationships with child welfare, but we just kept seeing the babies get taken away. And often at the time, birth alerts were still a common thing, and that's when a woman hasn't even had the chance to parent. She's pregnant, and an alert gets put on her clinical chart. And the stories weren't punching through, and I thought, okay, let me learn some of the privilege that I don't necessarily have. I didn't have the doctor title. I felt like we weren't being listened to. And I thought maybe I'll tell the story with numbers. And so I ended up doing a PhD more on the public health side, and very bad at math. I've always been bad at math, but figured out how to, with a lot of support from statisticians, if you know the Center for Gender and Sexual Health Equity group, got to combine some cohorts and work with incredible women. And unfortunately, we found what we kind of knew, which was that women who'd had their children removed after controlling for all sorts of confounders were 10 times more likely to die. And I'll never forget, receiving that analysis and doing it with the statistician and crying, because I was like, I know some of these women in this cohort. But it became really powerful, not because of our paper, but because we use that data as part of a coalition. And that's the other lesson, I think, for all of us passionate about health equity. And someone mentioned it earlier as well, and I can't agree with you more. Working with uncommon bedfellows, people who don't necessarily agree with you, is so crucial. So we had, folks from the child rights advocacy space that we worked with who, we had to explain, it's not in the best interest of children to be in foster care. There is now more Indigenous children in foster care than there ever was in residential school time. So if you agree that that's not a good place to be, let's help keep families together. And how do we support families so that they're not being ripped apart? And how do we support women who don't maybe have the same class privilege, who are racialized, and who aren't like me, that didn't have grandparents who could help when I was a young parent struggling? And how do we put services around for those women and those fathers so that they can also parent? And so that was a really powerful time. And we were able to, have some policy wins, like, for instance, birth alerts. They do still happen nationally, but they're no longer sort of a common practice in British Columbia, as one kind of example. And certainly we've seen, we hope, some light coming into the cracks. Still lots of work to do in child welfare. Oh, I pressed the wrong button. I had the immense privilege then when I moved to the UK to start to take some of this work global. And if folks are interested in working in global health, or if you're earlier in your career, I'm very proud to be sort of a colleague and peer in global health movement, because I do the work in my own community and I work here before I go somewhere else, and I always learn so much more when I'm working, and often you're there, I feel, in service to sort of tell policymakers or people with more power what the community members wanted, and it always drives me crazy that I have to fly there to do that. But this is me in Ukraine working with drug users and people who use drugs, and this is Olaf in the methadone clinic, and he discovered we had the same ring, and so we're sort of laughing about that. And I show it partly because the lesson in it for me is like authenticity and being yourself. I wear this ring that's kind of my tell around having some lived experience, and I wear it in Geneva. I wear it if I'm meeting the Minister of Health. I wore it when I met PM Carney. And so just being yourself, I think, is a huge lesson as a health equity advocate, and not being afraid to sort of share that, especially if you have some lived experience or whatever that means. I feel like the gold medal, if you watch the figure skating, the woman who won was like truly herself, and I think we're in that era of being authentic, particularly when trust is so important. The other lesson I take from this image is community co-design. So on the left side, you see we're in Sierra Leone working with women who are involved in sex work, and working with them to sort of listen and iterate with the community on HIV prevention programs. So we were doing an evaluation for the Global Fund to end AIDS TB. And just again and again, such powerful, talk about multiple crises they'd been through, the EVD crisis, HIV, so many major violence, war, conflict, but they had the solutions. They really didn't need people from Geneva telling them that they were doing it wrong. They just needed help to kind of tell the story better and capture the data so that they could continue to kind of get the checks from Geneva, because that's, let's be honest, what Geneva's for. This is an image of, again, lessons from the Ebola crisis. So if it's new to you, but probably most of you know about risk communication and community engagement, RCCE, is that a familiar concept? Oh, not as many as I thought. It's kind of, if you're a health promotion person, you're like, this is the Ottawa Charter written in a different way. Everyone loves to plant their flags in different terms, but in health emergencies, RCCE is a pillar that we use a lot, risk communication, community engagement, and it's sort of a framework to teach people how to work with community, and it can be a really useful tool if you're working with people who just don't kind of get it and they're not sure why you want to bring in people from the community to work on your health emergency problem. And so that was an incredible framework. We used it again in the Congo around safe and dignified burials. So I told you about prudence and people being afraid to come in through our door, but around burials during Ebola, it was an even more striking example where people were, there's always a kernel to a myth or a rumor or a misinformation or disinformation in my experience. And in the safe and dignified burials, again, we were coming in with our spacesuits before we developed SDB, and we were, when someone has lost their loved one, unfortunately in many cultures, if you're in my culture, in Irish culture, we spend time with our dead, and we might have an open time in a keening, and in Congo it's not dissimilar, and people actually will bathe and dress their loved one. Unfortunately, during hemorrhagic fever, that's a very viral time where there's a lot of virus in that loved one, and so that's where a lot of transmission occurs. So again, I was working for WHO at the time, the World Health Organization, and we're like, we got to get the bodies away from people. So we were literally kidnapping people's loved ones. And if you know anything about burial practice, that's a very bad thing to do. And we were doing it in spacesuits again. And so people started to become violent. When they saw us coming, they burned our centers, they threw things at us, but it took a lot of social listening and using RCCE tools, literally working with, we had anthropologists come in order to figure out why are they fighting us? I don't know. It sounds silly now, but it took us some time to really understand and work with community to realize there's got to be a better way. And what did a better way look like? Meeting with elders, meeting with faith leaders who said, well, give us those fancy spacesuits then, and let us do it. Let's do it together. Let's do the burial together. And so there are so many powerful lessons like that I've learned from the EVD outbreak. This is us also in South Africa. On the left, we're still in Congo, but colleagues, I'm part of the World Health Emergencies Program, so I have the privilege to get called out and go for a few months when there's an outbreak. And in South Africa, I spent part of the second wave of the pandemic there. And again, people were burning our COVID isolation facilities because we just weren't listening to community enough. We weren't working carefully with them. So what did we do? Some of the South African infectious disease docs were like, let's call the HIV community-based organizations, because their services are closed, and who's the expert at working with community? HIV providers. And so I was like, that's a great idea, because that's the same in Canada. So we ended up assembling the youth HIV/AIDS service organizations, the ones that worked with women, the ones who worked with queer community, and they ended up becoming kind of COVID prevention workers. And they were no longer out of work, but they also knew really well how to disseminate messages. And so that's something. When I came home, I think this is finally home. Yeah, those were the lessons, and what I love about global health work that we were able to apply here. When I was the regional director of communicable disease control in Vancouver Coastal Health, I was able to share some of those lessons, and we were able to do some of that same work with the Mpox outbreak. So if you're familiar with Mpox, was also a declared public health emergency because an outbreak is more than one expected case of something, and we didn't have transmission of Mpox at all in Canada, so that eventually became a global public health emergency. And with Mpox, we right away, it's mainly transmitted among men who have sex with men, so right away called HIM, which is called Health Initiative for Men, and is one of our one of our earlier AIDS service organization at the time. They were called ASO's contracts, and they were such fabulous partners. And I felt like my job as a public health nurse that wasn't from the community was to just kind of defer to them and let them guide what the response should look like. And so they, had vans. We were in bars in Davie Street. We were doing projects for people who didn't identify as gay men but could come in more discreetly. We had online testing. A lot of innovation during that outbreak through that community leadership. It was similar working in HPV. There's a paper underneath there where there's a really low uptake among certain faith-based groups, but also more in certain geographies. So we're doing some interesting mapping to really understand what are the communities where there needs to be different local messaging, and who can we partner with in order to increase the uptake of HPV vaccine, which prevents cancer in both young girls and boys. And then finally, there's a wonderful image of, if you know Dean Wilson, who's on the far left. Dean was the plaintiff in the Insight case, and he was bravely one of our first folks to get a COVID vaccine in the downtown east side. And I didn't lead this work. I think I was either in South Africa already or on my way back, but colleagues at Vancouver Coastal, Elizabeth Holliday and Miranda Compton and others, had the great foresight to work with Crackdown Podcast, which was a podcast that is really well regarded and respected in the downtown east side. And if you probably can't see the quote, but it actually sort of says, like, we don't trust governments. We want to kind of find out for ourselves whether or not this vaccine is safe. So they had the brilliant idea to interview one of the most trusted family docs that works in the neighborhood. They interviewed her, talked about the pros and cons of the vaccine. And then again, Dean, not unlike the, Adidas red shoes being worn by the most trusted, soccer player. We had Dean, who was really like, I would almost say like the patriarch of the downtown east side, agreed to get the vaccine sort of on camera, so to speak, on radio. And that along with a number of other strategies that the team developed was like hugely helpful to advance the COVID vaccine. And we had one of the first communities that was vaccinated, but also some of the highest vaccine rates in a community that normally does not, for very good reasons, trust government. And I think for many of you in the audience today, kind of my plea for those of you who identify maybe as scientists or as academics is that we are in an unprecedented era where trust in government is really declining. I recently left government to become an academic, so I'm a baby assistant professor at UBC now, partly because I feel like I really wanted to understand this work and solve some of these problems from both an academic and a practitioner lens. And then when this poll came out, I kind of follow this work like a hawk. If you don't know it, it's the Edelman Trust Barometer. And it, again, trust is declining, and particularly in the people who are most left behind. So from a health equity lens, it's people who have the highest social grievances, people living in poverty, people who the system is not currently working for. No surprise, they're the ones with the least trust. So I really hate the narrative around like misinformation, disinformation, where we sort of other people and where we say like these people are, oh, can you believe these MAGA people? That's not going to get us anywhere. Like we really have to understand what are these grievances about. They're often real. And how can we understand the kernel of truth underneath it, like the Ebola myths and rumors I told you about? And then how can we work with people to advance their issue, and how can we work in coalitions together to build a better world? There are so many tools, and I won't get into them, but very happy to share if anyone's curious. I often feel I think mis and disinformation is currently the World Economic Forum's, well, not I think, it is, greatest threat to humanity in the short term. And people feel like, well, what can we do? It feels hopeless. Who's worried about social media? I don't know if anyone else has kids, but like the impact of social media and AI, it can feel never ending. But as a practitioner and as a policymaker, there are so many simple tools that I learned from colleagues in West Africa, like myths and rumor tracking. It's not complicated. If you can get clinicians telling you this is what people are saying about this Mpox vaccine in Vimune. We were able to do that during the Mpox outbreak and have the experiences of the front line. We were able to do social listening using Meltwater to understand what are the myths and rumors in community, and then we were able to proactively pre-bunk those myths and rumors. And so myths and rumor tracking I'm a huge fan of. There's a lot of frameworks out there. This is from colleagues at Hopkins that are working on trust, and we're working to understand right now and build some Canadian versions of these frameworks. But I actually have a lot of hope, because if we can understand these lessons from social and behavior change experts, if we can understand and work really collaboratively with communications as clinicians, I think there's actually a lot more that we can do. And then again, that proximity, this framework leads us through different levels, but it's going to remain something we all know in our bones, which is like, and First Nations people have been teaching us since time immemorial, is that the local and the community and the land where you're on is how you're really going to be able to advance things and working together. And I'll just kind of close out with one of our colleague from WHO built this framework talking about health emergencies, and they both start in community and they end in communities. So we cannot do this work alone. And I've always loved this saying, no one is safe until we're all safe. It's something we said a lot during the pandemic around vaccine access, and it's kind of a quote that really speaks to me, but and that's, I think everyone who's here is probably converted into the leave no one behind world. But I do think we need to keep talking about health equity, making it real for people, kind of getting rid of some of the jargon and explaining to people why it's such a crucial way for us to stay together. And then I'll just close out by saying very grateful to my now 2 sons, and I'm raising, I hope, hopefully feminist sons. And yeah, it was very, it was a lot of privilege that I feel to be the first person in my family to have gone to university, to have gotten to get a PhD. I still don't understand how that happened, but it was it feels like a real calling to sort of leave the ladder up and to work on these issues so that everyone in the community is safer. And so I invite you to get in touch, and thank you for the opportunity.